Good morning, everyone. How are you? My name is Timisha, and I am also known as Mrs. Coda. So today we are going to talk about OCD, obsessive compulsive disorder, and how it affects our patients and what we can do as occupational therapy practitioners to one, help them, two, work with them. All right, let's get started. So I'm going to cover five different things. So the first thing I'm going to cover is we're going to define OCD. Then we're going to talk about the type of therapies, including OT, that people can have. We're also going to talk about the different types because there's different types of OCD. It's not all in one the same. I'm going to show you guys like a cycle on what happens with someone that's dealing with OCD. And then I'm going to give you a little story time of my experience with a patient I had that suffered from OCD in the skilled nursing facility setting. Of course, this falls under mental health, and you can do groups with people with OCD, but that can be a challenge. And we're going to dive in to explain why that could be a challenge. All right. OCD is defined as excessive thoughts, that's the obsession, then that leads to repetitive behaviors, that is the compulsion. Excessive thoughts that leads to excessive behaviors, hence OCD. So someone that is presenting with OCD will experience social isolation, anxiety, guilt, fear, depression, signs of hoarding, ritualistic behaviors. These are all signs of someone that is dealing with OCD. So the kind of therapies that someone can seek for OCD is CBT, which is cognitive behavioral therapy. We use this quite a bit when we're dealing with mental health, and you can just use this straight across the board when you're just dealing with someone that may have some cognitive challenges. Another therapy is called exposure therapy. That therapy is usually specialized. I believe there's a certification that you need to get to be called like exposure therapist. There's definitely training, but that is really taking that person and literally putting them in the situation. For example, if somebody is scared of heights, they're going to literally put them in a situation where they have to face that fear. Obviously, there's a buildup to it, but that is really what exposure therapy is in a nutshell. And then, of course, you have occupational therapy. So the focus with occupational therapy is really helping that person work through those emotions, which is affecting their ADLs, their IADLs. It's affecting their overall well-being. So our focus is different than a therapy perspective. We are working with their condition to allow them to still live their lives, whereas therapy is trying to work with them to either decrease the symptoms they experience or completely get rid of it altogether. So with OT, we're going to use techniques that require us to do adaptations. We're going to look at compensatory techniques. We're going to look at modification. And this really requires therapeutic use of self. We really have to pay attention to what they're saying and what they're doing. And that is going to help us when we try to have a session with them. And the other part of OCD is these people can get very angry, especially if there's something that um, kind of triggers them. So I don't want to jump ahead, but we'll talk about that a little bit more in detail when I get to my story. So as I mentioned before, there's different types of OCD. What I'm going to do is I'm not going to give you a list of everything because honestly, I probably don't know everything. But I'm going to give you the ones that I'm pretty familiar with that I have heard of or seen in my practice. So the first one is checking. Checking OCD is This is more of a fear-based of danger, a fear-based of damage. So, for example, they might be checking the fire alarm constantly. They might be checking for leaks, gas leaks, and they may constantly lock doors. And it's like they always have to check, like before they leave their house, they have to check that this is right, everything is okay. So it's a fear-based, usually checking comes from. Number two is contamination. So, contamination is, for example, there is a fear of shaking hands. They have a fear of door handles or crowds, public transit, public toilets. This is more like, they're constantly losing, what's it called? What do we use so much during this time of COVID? Hand sanitizer. There we go. I'm like, forgot completely forgot the term I was trying to look for. So they're constantly using hand sanitizers, maybe constantly washing their hands. Okay. So this is like a fear of being contaminated. Hoarding has its own separate diagnosis, but OCD also, people that are suffering from OCD also can hoard. Okay. And I don't think I really have to explain what hoarding is, but that is really just holding on to things, giving it sentimental values and not wanting to let it go. Next thing is ordering and symmetry. So I actually, when I get to the story, I actually had a patient that suffered from OCD, ordering and symmetry. And this is pretty much needing things to be a certain way. And if that thing is not a certain way, it creates like an anxiety. And I will definitely talk about the cycle, but that is another type of OCD is ordering and symmetry. Another one is intrusive thoughts. Now, this can be disturbing thoughts. This can be repetitive, unpleasant thoughts for the person. It might be thoughts of intrusion, violent, sexual, things that is to that person that like disgusting, and they're like, why am I having these thoughts? And it creates such a divide socially for them. um but yeah, these are the kind of, I would say, most often seen OCD types. All right, so I mentioned about the cycle of OCD. And this is like the typical cycle that someone goes through, or I should say, what is happening within their mind. All right. Again, I'm not like a psychiatrist or a psychologist, but this is just my basic knowledge from just being a occupational therapy practitioner. So the first cycle is they have the obsessive thought, which I wrote right here. And that obsessive thought becomes an anxiety. Okay. So it starts from having the obsessive thought, and then it becomes an anxiety. Okay. And that anxiety pushes them into a compulsive behavior. Okay. So when they're at the stage of anxiety, it makes them feel like I have to do this particular thing so I can get out of this stage. And this stage from anxiety goes into them actually doing the behavior. And once they actually do the behavior, they have a temporary relief. Okay, so then they have a temporary relief. So the problem is they get stuck in this cycle because they have a temporary relief, and then they find themselves having another obsessive thought. And if they don't fulfill it, it becomes an anxiety. Then they end up doing it, but then it becomes a compulsive behavior. They get the relief, and then it just keeps going around and around and around. Okay, so it's time for story time, and I hope that visual was helpful for you guys so you can kind of have an understanding of what is going on in someone's mind. So, real quick story. I'll try to make this fast because this video is going to be super long if I don't. Um, so, I was working in a skilled nursing facility, and one of my patients, when I was going through their chart review, I noticed that they had OCD. So I said, okay, so this person has this already in my mind. I'm like, okay, I have to thread very carefully. So I walked into the room. I knocked. Let me rephrase that. I knocked and I said, hi, this is Timisha. I am your occupational therapist. I'm just coming to conduct therapy with you. Can I please come in? All right. So I made sure I wait for them to say, yes, you may. Now, this is very important because you don't know. The thing is, I wasn't told what type they were, and a lot of times you're not going to be told what type. It might just say OCD. So, threading carefully, I waited for them to say come in instead of barging in on them and creating like a panic attack and then being completely kicked out of the room and the lack of trust is completely gone. So, anyway, so they say, yes, come on in. And this was a gentleman. And I made sure I didn't touch anything. So that's important. When you walk in, once you get the okay to walk in the room, you do not like lean on their desk or touch anything. Okay. I again repeated my introduction, like, hi, how are you today? My name is Timisha. I'm your OT for today, and I'm going to be conducting therapy with you. How are you? Okay. I make sure I say, how are you? Because I want to see what state they're in. If they're calm, if they just had like an OCD moment, just to kind of get a feel. And he was like, oh yeah, I'm fine, blah, blah, blah. I'm getting ready. I'm almost done. Okay. So, so I told the patient, okay, can I help you with anything? And he was like, well, you can. He wanted help getting his foot on his wheelchair footrest. So I said, okay. So before I touched him, I said, are you comfortable with me touching you with my hands, or would you like for me to put gloves on? And he said, no, you're okay. So I said, all right. So, okay. And then I also told him when I'm there, I said, okay, I'm going to go ahead and I'm going to grab your foot now and I'm going to put it on the stand. So I'm preparing him for everything that I'm doing. And this is key because you don't want to just say, okay, and touch him because you don't know if he has like an issue with being touched. Okay. If he has like a contamination type, you don't want to just outright touch him. So once we got ready, and I pushed him in his wheelchair down to the therapy gym. Before we entered, I said, we're going to enter the therapy gym. Is there a particular area you would like for me to put you in for us to begin our session? Reason I ask this is because you're in an open therapy gym. There's a lot of people in there. So sometimes people don't want to be in between other people. They may want to be on a certain area. So before we started, we're going to start out with like exercises. And I grabbed the bar and he's like, oh, wait, can you wipe that, please? And I was like, oh, I forgot. So I wiped it for him, right? And then long story short, we got through the session because I was being very mindful. I remember once we were done, he said, I really appreciate how you worked with me because some people don't ask me what I want. So the reason I'm telling you this story is because it helps you to be mindful when you're working with someone. You're not working on fixing their problem. You're helping them cope with their environment. Yes, we did exercises because that was part of his goal, but we also worked on ADLs. So I definitely made sure I took my time, verbalized what I was going to do, asked for his permission. And key thing is, I did not use, because sometimes in therapy we'll actually like do dressing with them. I did not do this. I used a TheraBand, and you can check out a video I have here on how to perform ADLs, upper body, lower body dressing using the TheraBand, so you don't necessarily have to do like the formal dressing with someone. And he was okay with that. I don't think he would have been comfortable with him performing his dressing in front of me or we using one of the rehab clothes that we have to do it. So I hope that this video was helpful. Please be sure to like, share, and subscribe, and make sure you turn on the notification bell so you know exactly when I'm going to be posting. And please, please, please subscribe to my channel. All right, guys. Thank you so much. Bye-bye.